fully understand how you feel. Although it's interesting, and it's true. This is a hard class. Like when I think about like, most of you guys are working full time. Like working full time and taking a medic class, probably one of the harder academic things that I've done. I have an MD and an MBA. So you get through this, you can do anything if you have any energy left. So we're going to talk about infectious diseases for an inordinately long time, and I just want to put a blanket statement out there that whatever is testable is what's in your book. I hopefully will not make a gram to milligram mistake and miseducate you guys, but every once in a while I misspeak. So uh, hopefully everything I say will align with it. Although I noticed there is one error when I was flipping through.
Well, you could have let me know. I would have fixed it.
Oh, I figured I'd point it out. I got there. So, infectious diseases. I mean, it's silly. Hep B isn't saliva. Anyway, so infectious diseases, what are they? It's sort of the study of the disease processes that occur when biologic agents affect our body. The the spectrum of infections that we can get is pretty vast, and so we're going to kind of do a brief overview of everything. We'll talk about uh, public health principles, uh, infectious disease standards, things that you do working with people that are potentially infected, and then we'll do kind of a tour of what's common infectious disease. And it's a weird topic for EMS because like cardiac emergencies, respiratory emergencies, these are things that you actively have to intervene on. Whereas with infectious diseases, for the most part, you just have to have a knowledge base of what's going on because most of the pre-hospital interventions that you have don't really act to cure the patient other than maybe sepsis and fluid, when you think about it, or pressors. But recognizing that is really important, more so for you than for the patient. You recognize when you need to be a little wary. Now that everybody's gone through COVID, that's pretty obvious, but before we didn't really care that much for most. So public health principles, um, we are living as biological organisms with biological organisms living inside of us. We have a symbiotic relationship for the most part, but every once in a while, pathologic bacteria primarily, but pathologic biologic agents get into us and cause havoc. So understanding that at the same time that we talk about these bacteria as pathogens, our lives couldn't exist in a way without them. So it's kind of an interesting dichotomy when you think about it. So it's important to understand, the patient and the population that you're dealing with, so that you can kind of understand what potential risks they are exposed to, so you can kind of come upon what type of illness they're having. Basic public health principle of the index case. The idea being that whenever there's an outbreak of something, the idea is you figure out where the index case is, and then you can go forward from there, figuring out who has it. You're trying to track down a population where it kind of comes. So there's a few agencies that are responsible from a public health standpoint. OSHA that writes the rules and regulations that y'all have to abide by in order to safely operate. The CDC collects data and research and puts out advisories. They're kind of mired in controversy right now. Kind of interesting. You have to know about the Ryan White Care Act, which is the law that delineates that we have to notify you guys or we have to notify your agency when you brought in somebody that has something that could have affected you. Primarily, we're talking about meningitis, HIV. Ryan White's HIV for exposure, but the law, I would say, ends up more so involving meningitis cases than anything else. There's the state and local public health departments, which it's funny, you don't really, you see little edicts that come out, but they're operating on a daily basis, collecting and gathering data from every hospital all the time about what's out there, so that they can put, notices when things are going awry. So as far as reportable diseases, there's like the three classifications that everybody's now familiar with after COVID. COVID kind of changed everybody's view of world knowledge base of infectious diseases. So something is endemic when it's within and among us. What's a disease that's endemic? Infectious disease. Fine, classic, right? Everywhere around us. But if you travel to, I don't know, Utah, it's not nearly as prevalent. Although it's kind of interesting, if you look at a map of, this is just a Lyme disease sidebar. If you look at a map of Lyme disease, where it occurs, you know, we're like the epicenter of Lyme disease, et cetera, like this whole area, and tick-borne illnesses. But if you look at a map of people with chronic Lyme, you know, chronic Lyme disease, it's uniform across the country, which tells you a lot of people get diagnosed with chronic Lyme that probably don't know.
Where they all came here first.
Yeah, they were here. You know.
Everybody moving out of New York.
It could be. And then, you know, we have outbreaks of disease that then potentially become epidemic, and when they become massive, they become pandemic. So, as far as an exposure control plan, every agency that operates in New York State has to have, I think actually every company that operates in New York State, but correct me if I'm wrong, has to have an exposure control plan. Anybody that potentially is exposed to biologic agents, which delineates that you need an exposure control plan. So if you go, whatever company you work for, or whichever municipality you work for, you can ask to see this exposure control plan and show you come up with one.
And they have to have a decal.
Dude. Designated infection control officer. That always cracks me up.
I know.
I know, right? Sorry, I'm talking.
You're good.
So, as far as individual responsibilities, we have a duty to not carry infections from one patient to the next or to ourselves. And so, having a proactive attitude is important. Maintaining hygienic practices, skincare, not having open wounds, and really the most important thing is hand washing. Hand washing, you know, like it sounds so trivial and mundane. You got to wash your hands. We go, not me, but our infection control teams in the hospital will do random surveys where they will have, they call them secret shoppers, and they hang out on different units of the hospital, and they sit there with a pad, and they write how many times people come out of a room and not wash their hands. ER, unfortunately, is almost always at the bottom of the list because everybody's rushing, you know, but you got to wash your hands or use an alcohol wipe for the most part, except for certain infections that are not alcohol wipe preventative. But it really is the most important thing. Just a very easy way to prevent transmission of illnesses. Obviously, handling and laundering contaminated forms, etc. Using body fluid changed appropriately. Never smoke your drink in the patient compartment of an ambulance. I'm surprised they say the patient compartment. People still smoke in ambulances?
Ed Becker.
Hmm?
Ed Becker still smokes in here.
I used to smoke in ambulances like that.
Adam,
Yeah,
she's
there's a
nice
difference
and,
between should
Yeah,
and do.
but the world has like moved on a lot. So I feel like it's more certainly a bad idea. Yeah, that's a good point. Everybody. Anyway, maintaining your own good health so that you don't get hurt or hurt other people accidentally, and obviously correctly disposing of needles and sharps and appropriate containers. Pretty obvious, but those are responsibilities you have to have. All right, infection, pathogenicity, and infectious agents. So, how does infection occur? In general, there's some terms you need to know. The virulence is just how pathogenic an agent is, whether it's bacteria, protozoan. There you go. It's in red. Good point. You know, how much infectious agent is required to transmit an infection? When we talk about wounds, like in, you know, how many bacteria do you think you need to get a wound infection? Anyone know?
2.
Yeah, 10 to the 8. You know, they say an average 10 to the 8. So that's what, 100 million? Or is that like in the tens of millions. But either way, you get the point. You need a lot of bacteria to cause them. And that's why they've done studies where they say about 10 to the 8th bacteria is consistent with what will be required to cause a wound infection. And just washing a wound out, just gentle irrigation with 250 cc's of normal saline under low pressure, usually brings it down to below 10 to the 3rd. So you can prevent wound infections, just by rinsing them out. Much less soap and water, God forbid. But so the dose is important. You can get exposed to something that could be potentially dangerous to you, HIV, but just have a small dose and not get it. So it really depends on, virulence, how much infectious agent, and that's why people that are untreated, like when we talk about HIV transmission later, people that are untreated HIV have very high viral loads. They can transmit it very easily to people that are exposed in the proper way to them. Whereas people that are on HIV medication, their viral loads tend to be zero. There's good data to show that they don't give their partners HIV that they're having unprotected sex with. So really, the dose is one of the most important things in determining the risk of somebody getting an infection. The resistance, the status of the host, the immune status of the host goes without saying. If you're immunosuppressed, you're at much higher risk of potentially getting an infection. And did the pathogen go through the correct mode of entry? Something doesn't get into the body in the correct way, it makes it less likely that disease will be transmitted. So all these things matter when it comes to determining whether somebody's going to get an infection, the chain of infection. So, like any circle, it's hard to say where things start. So germs live in a reservoir. Lyme disease, what's the reservoir? That reservoir actually resides on animals. Then the germs somehow get out from one person. This is transmission from one person to another. The germs get around. Then the germs have a portal of entry to get into the next person that's going to be infected. And that person has to be somewhat susceptible. They haven't had that infection previously, or it's been a long time since the infection has happened in them recently, so their immune system isn't primed if they have had it before. And then they then become infectious for a period of time. And so, what is this a picture of? COVID, right? That's the classic COVID picture. But it's a virus, like all viral pictures. Now that we have AI, the pictures have gotten much better. Okay. Stages of an infectious disease. So the latent, there's different ways of classifying where somebody is in the course of an infection. Latent and communicable. The latent period is after the person has been infected, but before they are actually able to transmit the infection to other people, or that they're symptomatic. And then the communicable period is when they can actually give it to other people. That is somewhat different from the other terms we use, the incubation period, which is with the time from when they get exposed to when they get symptoms. And the window phase is the period of infection in which you guys know about antigens and antibodies. Yeah, so antigen is anything foreign that enters the body, or that the body perceives as foreign. Autoimmune diseases are when the body mistakenly perceives part of them as foreign. And then our immune system responds and generates antibodies, which then tag the offending antigen. And our immune system looks for those antibodies, engulfs them, and the thing that they just tagged. Part of our immune system works. So the window phase is the period where there's antigen presence, so they have the virus in the body, but they haven't actually mounted an immune response yet. The disease period is when the first symptoms start until the resolution of those symptoms. And resolution of the symptoms does not mean that the infection agent is destroyed. It's true, but most infections, patients are not communicable after their symptoms are done. For the most common viral and bacterial infections, patients are symptomatic for a day or two prior to, or they're infectious from a day or two prior to when they start getting symptoms to several days after the symptoms appear. So, what are the things that infect us? Our bodies, we have normal flora in our bodies. Like I was saying, your gut has billions of bacteria living in them at any one time, coating the lining of our gut, and that they help in our digestive process. And there's more science coming out every year uh, that gut flora is actually more important than previously appreciated. Opportunistic pathogens, take advantage of when there's a gap in that gut flora when it's preventing them. So think about like yeast infections, classic fungal infection. Most vaginal yeast infections, the vagina is covered in bacteria normally. It's covered in, what's the bacteria? Anybody? I'm trying to remember. Well, Candida is Candida is the yeast, but the normal flora. I didn't say E. coli, but there's another bacteria that's super common. Yeah, it'll occur to me as I'm driving. Fortunately, it's not on your test. What happens is the lining of the vagina is covered in bacteria, and it has a protective effect. And then we take an antibiotic because we, have pneumonia or whatever other infection we think we need an antibiotic for. We take that antibiotic, and it inadvertently kills all the bacteria lining the area, and now there's an opportunity for yeast, to come in and cause havoc. And that's a common mechanism of infection. The bacteria that protect us stop doing so and do the things that we do ourselves. So bacteria, they're prokaryotic. They don't have the biochemical structures of reproduction are not contained within a single cell envelope. They can reproduce without a host cell, unlike viruses. And it really depends when it comes to infections as to what they're infecting, as to what symptoms are developing. Many bacteria have toxins that they secrete from their cell wall or that are within them, and when we kill the bacteria, there's lysis and those endotoxins, toxins inside, get released. So exotoxins are toxins that are basically chemical structures that are on the outside of the cell wall that are continually secreted by various bacteria and cause disease state or disease symptoms, causes a response in the human body. And endotoxins are the ones that get released most commonly when the cells die and lyse. And so there's a classic setup for the endotoxin disease. Anybody know what probably the most common infection is that involves endotoxin release that we see pretty regularly? Bueller? GU. So pyelonephritis. You guys know pyelonephritis, kidney infection. So what happens is E. coli causes you get a urinary tract infection. It travels up the urethra. For whatever reason, doesn't get treated right away. Maybe the symptoms weren't noticed. Maybe the person didn't realize or have time to get an antibiotic. And they travel up a little higher, and they go up the ureter, and eventually they affect the kidney. And when the kidney gets infected with bacteria, the kidney gets very inflamed, and you can get very sick from pyelo. You can die from pyelo, although it's quite rare these days. Most of the time, you get a fever, horrible flank pain, accompanied by dysuria, urgency, and frequency. And then the person's sick, they come into the hospital. We give them IV antibiotics to try to fight the infection. So the IV antibiotics then attack the bacteria, the E. coli, and you get cell lysis. And I don't know if you guys ever watched anybody with pyelo over the course of their ER stay or if they get hospitalized. We don't really hospitalize people very frequently for pyelo because they usually do well. But what happens not uncommonly when somebody has a legitimate pyelo is the natural course of the infections, they come in, they're febrile, they're sick, you start them on IV antibiotics, and then at some point they drop their pressure and they get hypotensive. And you're like, oh my God. And people that haven't seen this a lot are like, oh, they're septic. And they are, they fit the definition. And they are. Like if you actually do blood cultures on pyelo patients, it's a big pain in the ass because they come back positive, and then you have this person who's at home with positive blood cultures, and you have to call them back. Whereas what usually happens is these bacteria lyse, they release the endotoxin. I forget which endotoxin it is, and our immune system responds to that endotoxin and causes a complement cascade, and we get vasodilation, and that's when your pressure drops. And then we give them lots of fluid, and by that time, you should be getting IV antibiotics and make a difference, a dent in the infection. Blood pressure comes back up, and most people with pyelo do fine after that. Put them on antibiotics for a week, do okay. But that pressure drop is endotoxins causing antibiotics causing cell lysis, which is causing endotoxin release, which is causing that toxic like retention that happens, and then it resolves as the number of bacteria are getting killed. So pretty interesting. Like you see it all the time. You don't really appreciate that that's what's happening. So viral infections are a little bit different in the sense that viruses, they're not, I mean, there's always a big question, like, are viruses alive or not? Viruses are really just a collection of proteins in a unique way. They can't really reproduce outside of a cell. What they do is they, and maybe this is post-COVID, everybody knows it, apologies, but they invade the cell, transfer into the cell, and they use the cell's own reproductive framework to make multiple copies of their own genetic code, to the point where that genetic code, those copies then kind of get out of the cell nucleus and fold to becoming more viral proteins, and until the cell is just so full of them, ruptures, and then those viral particles are now go and attack other cells, and that's the cascade that happens with a viral infection, and that's how viral reproduction sort of works. So they can't reproduce without a cell to invade and borrow its sort of genetic instruments. So they're obligate intracellular parasites. So we've got a host of other potential infectious organisms. Fungi have very thick cell walls that protect them from being engulfed by our body's immune system. Protozoans are single-celled parasitic organisms. Prion diseases are like kind of the thing that really scares me, because we don't really have a way of treating them. And there's only a couple right now, but it's always like the things that like kind of like avian flu. You're always waiting, knowing that like at any one point the avian flu could jump into humans and cause another pandemic. Prion diseases, we don't really have any treatment for them. And if they were ever to become sort of invasive in a way, then we'd have billions of dollars to, develop a treatment. Maybe we'd have a treatment in 3 months. Never know. But currently there isn't any. And then there's parasites, which are usually one of the like protozoan in immunology, and then there's worms. So other microorganisms, helminths, they're not microorganisms, but they're one of the most common infections worldwide. We don't really see them in the U.S. very much, other than maybe pinworms. You guys know what pinworms? That's like the classic. What's the pinworm disease is basically when a disease of toddlers, they get pinworms and they burrow in the canal, and so they're like the parent comes in and they're like scratching the butt, and there's a test called the Scotch tape test that no one does anymore, but you used to just take a piece of Scotch tape and put it right on the child's penis, fold it, and put it in the microscope, and you can actually see them. And so that's how the diagnosis is classically made. Now I think people are mostly like, yeah, it's probably that. They just get a prescription. Thought about it. I haven't seen a case in probably 10 years. Or maybe, like, I feel like there was one case sometime in the last 10 years that everybody was like, oh my God. Hookworms are common outside of the U.S., not common to us. And this isn't just children, but barefoot people walk in areas that are contaminated with animal feces that have hookworms, and the worms travel up through the break in the skin, ultimately can travel, and I forget the natural pathogenicity of the cycle of worm infections, but it's crazy. It goes through the body. And then trichinosis is a very common one, South America and Central America. I used to work in LA, and we used to read our own CAT scans all the time. And when I first started working in LA, I was like, what is that? And you see these cysts on people's CAT scans of their heads from Central and South America all the time. Like, I wouldn't say 1 in 20. I'm making that up, so I don't know what the real number is. But very commonly, you see these little cystic structures. And those were evidence of prior trichinella infections in Central and South Americans. Working in LA, 80% of the hospital patients that I saw were from Mexico and Central America. And so being under raw and undercooked pork products is how it develops. And they develop the worms, they burrow and develop cysts and kind of throughout the body. But they can cause problems if they're in the brain. Did anybody see that episode of not House? What's the one with McDreamy and Grey's Anatomy, where they were like trying to do a brain surgery to take the cysts out? But there's like some truth to all of these things. I mean, the pit is probably it's actually real, but Grey's Anatomy isn't. But they, what can happen is these cysts can cause problems if like you can get CSF obstruction, so they can get cysts in the canals draining the CSF. You get hydrocephalus from it. And it's not a very easy thing because if you give medicine to treat the cysts, a good chunk of the time it causes an inflammatory process, and you don't want an inflammatory process happening in your brain. And so most of the time, just sit there, and if they're not causing hydrocephalus or obstructing, you just sit there and no one does anything about them, and that's that. But it's very interesting to see so many people with it. Cook your pork. Sure. Right.
What's the
How long
temperature?
do you need to
Yeah,
barbecue?
what's the temperature for cooking
Smoking
your
pork. So, post-defense mechanisms. So we've got an array of defense mechanisms to prevent infection, right? So we've got our external barriers, our skin, our mucous membranes, everything in our airway that sort of protects things, the whole mucociliary elevator, etc. And then we have sort of second line of internal defenses. We have an immune system. We have white blood cells that fight infection. 5 different types of white blood cells involved in the immune system. We've got defensive proteins, like we call the complement system in our body, helpful in the immune response and helps produce the inflammatory response. And it's this inflammatory response that goes awry in cases of sepsis. It's not really the acute infection as much as the response to the acute infection that triggered sepsis. And then we have, our immune system, our B and T cells. Well, it's been so long. The B cells, I think, I don't remember the exact which cells end up
B cells are your
make the antibodies.
Yeah, the T cells are your helper T cells and your phagocytes.
That's what happens when you get old. The fact that you remember it ruins that.
Especially since we're the same age.
But it is what it is. So anyway, we eventually, our immune system has a memory mechanism. And so we get an infection, our body sees an antigen, we create antibodies. And in addition to creating the antibodies, we create a memory of those antibodies. And so that when we're re-exposed to that particular antigen later in the future, our body can check and say, yes, we've had this, and then start generating antibodies very quickly against that antigen, preventing you from ever clinically getting sick. And that's why there are certain infections you can obviously get again, like rhinovirus, everybody gets frequently over the course of their lives. But most infections are kind of one and done as long as your immune system is functioning well. Of course, immunogenicity or the immunologic state wanes over time, and so the longer you go, you can potentially get reinfected. So wash your hands. That's fine. So decontamination. So there's different levels of decontamination that you have to know. Low-level disinfection is really just using slightly heavily diluted bleach. And an intermediate level disinfection for equipment, 1 in 100 bleach solution. High-level disinfection is anything that you're going to be using on other patients with regularity. And we have various products that you have to put on, and they have to be applied for at least 30 seconds to a minute before they are fully functional. And then sterilization is the highest level of contamination, and that involves basically heating something to the point where nothing can survive it. Although interestingly, there are infections now that have surpassed our ability to just with sterilization. Anybody know the big pathologic agent that's kind of in the infectious disease radar and scope lately? Around here too. C. auris. Have you guys heard of C. auris? Candida auris. It's a candida that's pathologic. It affects immunosuppressed people and can kill. And it's highly resistant to sterilization and everything else. So that's why everybody's kind of freaking out. Good news is, if you're not immunosuppressed, not gonna get it, but at least right now. That's like sort of on everybody's radar because there are cases in hospitals in this area that have had C. auris. Okay, so what do you need to do when you know that there's a suspected infectious disease on the horizon? Really, the most important thing is to be aware of it, right? To be aware of the potential. Once again, this is like a post-COVID world. Everybody knows, you're going to a house where somebody's sick, you're going to put a mask on. But previously we didn't, right? People didn't wear masks throughout flu season. Since we started, I don't know if you guys anybody been doing EMS before COVID?
Mm-hmm.
I don't know if you tallied how often you got sick, but I don't get sick anymore. I wear a mask like anybody that I think might be potentially sick. We all mask up so easily, and I find that I don't get sick nearly as much. Now my immune system isn't primed against all these things, so later when I quit, there might be a benefit of getting. So, having suspicion is important. Wearing the proper PPE for whatever you're going into is important. When you're approaching a patient with a potential infectious disease, this is the kind of information that's useful to you, right? It's the same as any other patient encounter. You want to get all of the PRSD and the actual story, and hopefully it fits something that you've learned as far as certain types of infections, and that's what you do conclude that the person is probably so getting a good story. Is there fever? Fever isn't uniformly present in every infection, and it's important to realize that because a lot of times I hear people say, like other doctors say, "Oh, there's no fever," so there's no, a huge chunk of elderly with acquired infections now no fever. They just don't have a good immune system, and so they don't make a big reaction to it. Not even counting like really immunosuppressed people, just being old. And so the absence of fever doesn't disprove an infection, but the presence of fever should definitely clue you in that there's very good odds. There's only a couple things that give you high fevers in general that are not infectious. So for the most part, fever equals infection, and you kind of prove otherwise or have some suspicion that there's something else awry. Antipyretic use, are they using Tylenol? Is this masking the fever? That's the other thing. So there's no fever, but they've been taking Motrin around the clock for their body aches. Of course they're not going to have fever. They have neck pain or nuchal rigidity. Obviously, red flag for meningitis. Difficulty swallowing, secretions. How have things evolved over the time of the illness? So what other history do they have? And really, this is the red flags for picking up whether somebody is immunosuppressed effectively. Besides, the reality is just being old makes you functionally immunosuppressed. But chronic infections, does the person have a history of chronic infections in the past? Are they on steroids? Patients on steroids are immunosuppressed very commonly. Not always. And your body, like a healthy person taking a steroid is still going to be able to fight an infection. But people that are on prolonged steroids, they are effectively immunosuppressed. Do they have a disease condition that requires them to be on medications that immunosuppress, so to speak, to prevent rejection? So organ transplant patients are always at high risk because the medicines they take to prevent rejection put them at risk of acquired infections. Are they diabetic? We all know diabetics, everything bad happens to diabetics. So effectively, poorly controlled, I should say, everything bad happens to poorly controlled diabetics. Well-controlled diabetics do great, but the ones that aren't, they tend to be essentially functionally immunosuppressed. And it also puts them at risk for other things. What's the most common diabetic symptom that ends up leading to infection? Neuropathy. Neuropathy is like the bane of our human existence. Diabetic that's poorly controlled eventually stops feeling their toes very well, and then they're walking and they just get a nick in their toe on something that they didn't see, and they didn't feel, and then they have an evolving ulcer, and that ulcer turns into osteomyelitis, and then they start losing a toe, and the infections, if they stay poorly controlled, they progressively lose things between the infections and the terrible vasculature that results from poor diabetic control makes them functionally at high risk of getting infections. COPD, respiratory complications, patients that have poor lung function, they don't have any mucociliary elevator. Smokers, when you smoke, you paralyze the what are the hair cells called? Cilia. What are the hair cells in the inner ear? You guys remember? Something of corti, hair cells of corti. Your inner ear, you have these hair cells that are involved in the neurologic transmission of auditory signals. So COPD, respiratory complications, moving along. So you want to get a good assessment. When you're doing your physical exam, are they febrile? EMS, we never used to carry temperature thermometers. It's become kind of standard now, which is great. Because it's the fifth vital sign, more than pulse ox, because you guys always did pulse ox that didn't have a thermometer. But knowing if somebody has a fever is huge, right? And a lot of times you can't tell. What's the best way to take a temperature?
Rectally.
Unless you're the patient. Yeah.
It's Pride Month.
It's what? So, yeah, just assessing the patient if they do have a fever, it steers you down a diagnosis. You have a patient with respiratory difficulties, and they have a fever. Are you going to say it's CHF? Probably not. Differentiating CHF from pneumonia sounds obvious, but it can be very tricky. And if there's a fever, then you're definitely steering down somewhere, one path. So knowing that is useful. The rest of their exam, are they jaundiced? Are they modeling? Are there rashes present? They have petechial rashes present. That's a red flag. Scleral icterus kind of goes along with jaundice, tells you that their bilirubin is elevated for one reason or another. Do they have neck stiffness or pain when they're trying to flex their neck? Do they have lymphadenopathy? When you're listening to their lung sounds, do you hear a focalized area of bronchi? They have hepatomegaly. It's all focused on hepatitis for right upper quadrant tetanus. Do they have purulence anywhere? On that note, we begin our tour of infectious diseases. So sepsis. So sepsis is the big thing in medicine in the last 10 years, and I think there's if you ask providers in general about how they feel about sepsis care, sepsis and then the sepsis care that's evolved as a result. And I don't know if you guys know this, but basically sepsis in hospitals, CMS Medicare has taken over dictating how sepsis care should be managed, and it's very well intended because previously unrecognized sepsis led to significant lives lost in hospital mortality, but they really overdid it. And I could talk for an hour about sepsis, and you really don't want to listen. But the point being that there's certain things that are really important for sepsis, like early antibiotics and adequate fluid resuscitation. But there's the CMS has a 243-page rule book on how sepsis care should be handled. So every patient in the hospital that gets diagnosed with sepsis gets reviewed. You have to basically be an expert in sepsis to interpret the rule book, and it's ridiculous. And it's so over dictates everything that it's sort of designed as a way to prevent payment. That's very suspicious. That ultimately it's just a means of punishing hospitals so they don't have to pay it. Medicare doesn't have to pay as much. But I'll get off my soapbox. So that being said, so what is sepsis? Sepsis is it's our body's response to the presence of an infection in which that response goes out of control, sort of like CMS. But what happens is, our body mounts a normal response to an infection, and something triggers that response to be a little bit overboard. And as a result, there is a release of complement into the bloodstream that's way kind of over the top than that's necessary, and that hyper reaction to the infectious agent is what causes us to suddenly become hypotensive and ultimately shock if unrecognized in a timely manner. Really is like the end result of all these infectious diseases. And then, it does require rapid treatment, mainly antibiotics and fluids to prevent tissue damage, organ, and death. So who's at risk of sepsis? It's always the same answer. Whenever anybody asks you who's at risk for blah, it's always the very old, the very young, and immunosuppressed people. That's what the answer is. So, as far as we define sepsis, you guys all know this already. Am I like? I'll say it anyway. So we define sepsis essentially as having the presence of SIRS, really, the systemic inflammatory response syndrome, which is basically two or more vital signs being out of whack, and the presence or suspicion of infection. So SIRS criteria: fever or hypothermia, heart rate over 90, over 20 breaths per minute, or a PaCO2 of less than 32, which means the person is hyperventilating. For a low white count or a very high white count, or a lot of bands. Bands are basically immature neutrophils. Neutrophils are one of the 5 types of white blood cells, and the presence of them being high is raises the suspicion of infection. And bands is basically means the body is just spitting out white blood cell neutrophils as fast as it can in order to respond to an infection. So, 3 of the 4 of these are clinical. You don't need any lab values or anything to sort of diagnose sepsis the majority of the time. So, having over 2 of these is the definition of SIRS, systemic inflammatory response syndrome. And SIRS is just a general term for the body is going, something is going awry in the body. And you can have SIRS from lots of things that are not infectious. You can have pancreatitis can give you SIRS. Trauma essentially gives you SIRS. It really just is a general term for badness that's happening. But then when you have infection, or confirmed or presumed infection, then the combination of the 2 is sepsis. Now, severe sepsis is defined as sepsis plus some level of organ dysfunction, and that can be like, a lab parameter. For instance, somebody's bilirubin is elevated, or their platelets are very low, so their hematologic system is failing, their liver is failing, or clinical, they're in respiratory failure, so somebody's not breathing adequately as a result of the infection. That defines severe sepsis. And then if somebody has severe sepsis and they're refractory to a bolus of fluids and they're still hypotensive, that's septic shock. Usually needs pressors, all the above care. And then multiple organ dysfunction syndrome is basically when multiple organs are failing. So, the management of sepsis is really just aggressively intervening, ideally with antibiotics as soon as possible. I think at the end of the day, we have all these little sepsis treatment algorithms that we have to follow, but the net result is give fluid to adequately resuscitate the patient and give antibiotics. And I think with all the sepsis care and all the stuff that you have to do in that 243 book, at the end of the day, giving antibiotics early and giving fluids is they could have made it a one-page book. It seems that these are the things that matter, along with supportive care. If somebody's breathing inadequately, you breathe for them, help them ventilate, etc. So HIV, positive agent of HIV, human immunodeficiency virus. There's HIV-1 and HIV-2. HIV-1 is worldwide. HIV-2 is pretty limited to Africa, and we don't really see. I've never seen a case of HIV-2. I don't know what the prevalence of it is outside of Africa. There are retroviruses. They basically cause a very similar illness, but we see HIV-1 much. We see HIV-1. We don't see HIV-2 at all. Transmission is bloodborne primarily. Sexual contact sharing of HIV contaminated needles and syringes, infusion of blood products. That used to be a very big problem when HIV first came out until they realized that it was bloodborne, and then since then it's really limited because all blood is screened for HIV. And so it still probably happens at some incidents, but the incidence is so low that I would consider it really not much of a risk in the United States. What happens in other places in the world, never know. Contact with semen, blood, vaginal fluids is also high risk. Transmission, this is for HIV infected mothers. There's a 1 to 2% transmission to infants. I think actually the risk was like, now I can't remember the actual risk, untreated risk, but it's lower than this now. Effectively, you can get a mother to have a viral load of 0 by the time they're delivering a baby. So if it's recognized early, that transmission doesn't occur anymore in our healthcare system. The person's being cared for. So we all worry about getting HIV from a needle stick. That's like the thing you worry about in healthcare. I would worry much more about Hep B and C. Statistically, the odds of getting HIV from somebody who's infected with HIV with a hollow needle is about 25%. So that's a 1 in 400 chance. It's a pretty good odds when you think about it. It's pretty unlikely to the point where a lot of people just refuse, won't take retroviral medicine. 1 in 400 is pretty low as far as versus taking medicine for a month. Everybody's got their own opinion on that, so we offer it to everybody when they have an exposure. A lot of people I've found don't take it. And medicine has side effects too. So that being said, the things that make things high risk is a deep stick with a large hollow bore needle. Obviously, the blood is inside the needle. With solid needles, it's less likely. Visible blood on the device, HIV positive patient with high viral load. These days, most HIV patients that know they are HIV positive are taken care of and they're on antivirals. And when they're on antivirals, it's really not like when I ask patients that have HIV in the emergency room what their viral load is last time they checked, it's rare that I get an answer that's not 0. Which kind of tells you that people that are on medication, the chance of actually getting an acquired infection from is pretty low. And now, like when you talk about like just the needle stick, so let's say hypothetically you didn't know the patient, right? You were cleaning something up and there was a needle there and you stuck yourself with it. So if that patient had HIV and it was recent that it was in somebody, you're talking about a 1 in 400 chance. But independent probabilities are multiplied in order to come by, so then you have to ask yourself, what is the probability that this needle was HIV infected in the first place? So then you look at the incidence of HIV in our area versus the incidence of all patients getting healthcare. And I couldn't give you that number, but I would tell you the number is probably pretty low. And so then you're multiplying 1/400th times that probability, and you're going to get your result is going to be in the 1 in a millionth something, right? So statistically, if you don't know the status of the person or the needle that you just got stuck with, chances are you're going to be fine. Now, I'm not saying that you shouldn't take HIV medicine if you got exposed, but do the math. The chances are low. It might. I don't know. Hasn't happened to me in a long time. But I just want to reassure you that like you're not going to die if you get stuck with a needle. It's very good odds. You're just fine, even if you did nothing. So, signs and symptoms of HIV infection. So there is this period called this phenomenon called the acute retroviral syndrome, which is when somebody gets a retrovirus and is acutely infected. I think it says for like 4 to 6 weeks after infection. It can happen like within days to weeks after. I don't know. I'm pretty sure it can happen sooner than 4 to 6 weeks, but it's pretty rare to happen after 6 weeks. And it's just a general mild flu-like illness. Like if you didn't know, you would just think that you were like, got some kind of a bug. You feel swollen glands, sore throat, body aches. Respiratory symptoms are not very common, although some patients with retrovirals do have a sore throat. But the most of it, they don't have, runny nose and cough. It's I guess a good way to it's sort of like a mono-like illness. Think about mono, which I think we'll talk about anyway. But you have swollen nodes, splenomegaly, and it lasts a week or two and then goes away. And that's the acute infectious period, the acute infection that somebody gets when they get infected with HIV. And then they don't know if they don't test or they forget about that illness. They have no idea that they're HIV positive, and they do fine for years without, meanwhile their viral loads are going up and up, but they're asymptomatic. And at some point, HIV starts affecting the immune system of the body. Specifically, it kills off the CD4 cells, and as the CD4 cell count goes down, they start being vulnerable to opportunistic infections. So when somebody's CD4 cells go down below 200, then that's an AIDS. We transition from calling them HIV positive to having AIDS, acquired immune deficiency syndrome. And those patients then frequently will succumb to opportunistic infections that people otherwise wouldn't get. So out-of-hospital care is supportive. Yeah, I mean, this is more for knowledge as opposed to something that you're going to acutely manage pre-hospitally. Obviously, protecting yourself from exposure to bloodborne pathogens in the patient population is very important. So once AIDS sort of arises, and it can be defined by either the presence of the CD4 count below 200 or the presence of one of these infections in somebody who is HIV positive. These people will develop various things. So TB is a common co-infection of people with HIV. Kaposi sarcoma, which there's a slide for, they'll start to get various sort of signs and symptoms of unwellness. And usually with lymphadenopathy, splenomegaly, they have other infections that they've gotten, like CMV, cytomegalovirus, which normally wouldn't be a problem for most people. It becomes a significant infectious risk for people that are immune suppressed. Ultimately, untreated patients can develop neurologic disorders. Actually, there is some association with some of the HIV therapies with getting progressive neurologic issues as well, poison. So Kaposi sarcoma is really a skin tumor. I mean, it's a type of skin cancer, effectively, but it's an opportunistic one. And it looks kind of similar to a lot of squamous cell carcinomas. Who knew? Did you put those in there?
I did.
Yeah. You guys want to take a break?